Sexually transmitted infections. They can take something as wonderful and pleasurable as sex and make it a source of anxiety and frustration. Dr. Jabran Sheikh, board certified dermatologist and longevity medicine doctor. Today I want to talk about sexually transmitted diseases, something that I see and think about a lot in my practice as a dermatologist, and something that I seek to aggressively prevent to really bottom out risk in my longevity medicine patients. There is nothing that can ruin longevity and health span than the most feared consequence, which is HIV, which is still out there, and we have a lot of amazing ways to prevent it now. And in terms of reducing quality of life, common sexually transmitted infections such as genital warts, which can be a source of anxiety and frustration and can be quite difficult to treat, syphilis, chlamydia, we're going to talk a lot about them, as well as herpes. Herpes is forever. So the best and most effective way is preventing it, but if you already have herpes or if your partner has herpes, there are ways to prevent transmission or reduce outbreaks. So join me for this deep dive, sexually transmitted infections. So let's talk about the main ones. Today we're going to talk about chlamydia, gonorrhea, syphilis. We're going to talk about the big one, which is HIV, and other viral ones, which include HPV, which is human papillomavirus, the common cause of genital warts, as well as herpes simplex, that's genital herpes in the context here. And then we'll also have a brief discussion of another virus called molluscum contagiosum, which is commonly a sexually transmitted infection. Most people don't seem to know about that one. We'll talk about screening for them, we'll talk about how we prevent them, and then I have a couple of pearls that I use in terms of treating my patients that are kind of, I wouldn't say against the standard grain, but I would say that they are a little bit different and they're not exactly in the standard guidelines, but I think about it a little differently in terms of how I treat it. Like I said, I aggressively try to prevent it, and so some of the ways that I approach it are a little bit unusual compared to guidelines. So gonorrhea, chlamydia, those are both bacterial infections. They cause urethritis in men, which is a painful, milky white discharge, discomfort with peeing. They're very, very common, and they go through periods in which they increase or decrease. So we're incredibly effective at treating them. They're part of any standard sexually transmitted infection panel. So whenever you get STD testing, that's a standard test that's going to be done. And one of the new innovations that we have now in the MSM, or men who have sex with men community, is doxy-PEP. So you probably heard of PrEP, which is pre-exposure prophylaxis. That's used for HIV. But there's also PEP, which is post-exposure prophylaxis. That's the use of doxycycline after a sexual episode or multiple sexual episodes in which the risk of getting one of the sexually transmitted infections is high. You take doxycycline afterwards, and that can prevent it if taken at early enough. So for my patients who are perhaps more promiscuous, have many sexual partners, or are going to a sex party, for example, or swinging, this kind of thing, I think doxy-PEP, which is the post-exposure prophylaxis, is reasonable for those patients. Communities in which there's a high rate of sexually transmitted infection, sex workers, and then in the MSM community and in certain populations, I think it is totally reasonable. But very importantly, regular screening every 3 months or so is important because it's not 100% effective. Syphilis is another bacterial infection. Syphilis is having a resurgence right now in the men who have sex with men community. I've seen it in my gay patients quite a bit. And when caught early, it's just a minor nothing disease. When it's caught in later stages, it can be quite catastrophic. It can cause neurological dysfunction, cardiac dysfunction, all sorts of downstream problems. And that's treated with penicillin. And importantly, the doxy-PEP that I just said for gonorrhea, chlamydia also seems to protect against that as well. So again, regular screening in high-risk patients is absolutely critical, but the doxy-PEP, if taken within 48 hours of the potential exposure, is quite effective at treating it in its ultra early stages. Next, we got HIV. So HIV was a devastating disease and killed a lot of people throughout the world, sub-Saharan Africa, and here in the United States, in the Western world, in the MSM community. But it struck regardless of sexual orientation, regardless of age. It really was a catastrophic disease throughout the 90s. And now we have fantastic antiretroviral therapies. These are therapies that if you have HIV, they prevent the progression of HIV into AIDS. And they're very, very effective. The greatest in the last 5 to 10 years has been PrEP, which is pre-exposure prophylaxis. So that's exposure before you get exposed to it, among sex workers, among who are in high-risk communities such as the MSM community. They will take tenofovir, which is a antiretroviral, and they will take it every day, and it tremendously reduces the risk of acquiring a new HIV infection. It's remarkably effective. So in my MSM patients, I think PrEP is totally reasonable. My straight patients who are having a lot of sex and who are just more concerned about it and want to reduce that downside risk, I like a approach which is called the in the pocket or driven PrEP. So the idea is, patients who are having ongoing regular exposure, it's reasonable to take it every day. But there's another protocol that is also incredibly effective, in which you take 2 of the tenofovir pill 2 and 24 hours before the first episode of sex. So it can be as early as 2 hours before. That's a pretty good window. And then 1 day after and 2 days after. So 2 days, 2 pills, 2 hours of the first episode, and then for the next 48 hours afterwards. That's very effective for people who are going to have more episodic sex, and their risk is more episodic, but they don't necessarily want to be exposed to the medication on a daily basis. And I think that's reasonable for whoever wants it. Know their risk factors. Patients know their risk factors, and the reality is that I'm totally agnostic about what it is. And with this kind of less pill exposure, I think it's a great to address it when the risk actually is there. And it may not be every day, it may be a few days a month, for example. When we think about herpes, so herpes is forever. Genital herpes, it's painful blisters on the penis and the genitals in general. It is get all sorts of, some people get 1 episode and they never get it again. Some people don't even know they had it because it was such a minor first episode. Other people are just getting episode, and it's really frustrating, very painful, afraid about transmitting it to a long-term partner, and a lot of it's very stigmatized. It's something that's a very difficult conversation to have with new partners. So there are 2 approaches for the treatment of herpes. We can't cure it, but we can really reduce shedding. We can make the symptoms go away faster. We can the lesions pretty quickly with a medication called Valtrex or valacyclovir. And there are 2 approaches. There is the event-driven approach, in which patients will take 2 grams at the first sign that they have a outbreak. They feel some tingling or itching or burning in the area, and it can abort the whole episode. That's very effective for patients who want to do an event-driven approach. And then there's daily suppressive therapy. They take 500 milligrams to 1 gram, depending on how many they're having per month, somewhere between 500 milligrams and 1 gram a day, and it can just prevent it. And that's just a new pill that they take every single day. That's really fantastic, because there's a great study in the New England Journal of Medicine, the best and most important journal in American medicine, which showed that in a patient who has herpes, who has an episode of herpes serology, meaning in their blood you can tell that they were exposed to herpes, they had the rate of transmission to a herpes naive, meaning no exposure to herpes, in a patient who takes Valtrex single day. They randomize them to Valtrex or placebo, and they found that the rate of transmission to the partner who does not have history of exposure was incredibly good. It really reduced the risk. I don't remember the exact number, but I think it was maybe an 80% risk in transmission. So not perfect. There's always a risk of asymptomatic shedding and spreading it even when you don't have symptoms, but really substantially reduces the risk with daily suppressive therapy with the Valtrex. So with my patients who are particularly concerned about getting herpes and they want to really bottom out that risk, what I'll do is I'll check serologies. The first question that I have is, have you ever been exposed to HSV1, classically associated with oral herpes, HSV2 classically associated with genital herpes? Of course, there's a lot of mixing, and you have HSV1 on the genitals and vice versa. If no exposure before, they have no serologies, meaning that they've never been exposed to herpes, the same event-driven approach that we do with PrEP, where it's a person who can take Valtrex to prevent the potential acquisition of herpes. And so I think that they can start it in the same way, probably 1 day before, during ongoing exposure, and then 1 to 2 days afterwards. It's worked very well. If they have previous exposure to herpes, but they've never had an outbreak, I don't really know what to do with that in a lot of patients. I think it's, their chance of getting reinfected is low, and I don't think that it justifies taking the if they've never had an episode and they've already been exposed to it. So I think I would in that case for if they have symptoms, in which case we do that, either pill in the pocket, first sign we did, or daily suppressive if they're getting recurrent episodes. But if you have exposure and something like 20-30% plus of the population has exposure, and they're listen, I never had an outbreak once, so it's possible your immune system is just very effective at keeping it under control, and you may never have an outbreak. And so the reality is that subset have been exposed and will just never have an outbreak. So this is only a strategy for patients who have never been exposed and want to really bottom out that risk of exposure. So other, about the bacterial ones, gonorrhea, chlamydia, syphilis, and doxypep. We talked about PrEP for HIV. We talked about herpes simplex and Valtrex. Molluscum contagiosum, that's a virus. It's a pox virus and related to monkeypox, which we now, of course, have great vaccination against. That is out there. It's transmitted through close sexual contact, something to be aware of. There really is no protection against that. It's just more identification. And then we have destructive therapies that I, as a dermatologist, will do in the office, liquid nitrogen and other approaches. The last thing that I want to talk about is HPV. So HPV is an interesting virus. Classically, we think about it for women as the cause of cervical cancer. In the 90s and 2000s, there was this fantastic vaccination, and we reduced the risk of the highest risk types of HPV that cause cancer, and those levels are really plummeting, and that's really wonderful. But boys, vaccinated against it, which protects them from giving girls the high risk types of HPV, and also the 95% of the strains of genital warts, which again are painful and uncomfortable and unpleasant. So today are vaccinated, but there is a wide range of men who are in their 30s, 40s, 50s who never got vaccinated, and they missed that window of opportunity to get vaccinated. Well, it has not been publicized, and it's a topic that I proselytize about, is that men up to 46 years old in America can go and get vaccinated against HPV, and it protects them from all the strains, 95% of the strains of genital warts, and I would say much more importantly, head and neck cancers. So a large subset of head and neck cancers of the esophagus and of the throat, area in the mouth, are caused by high-risk HPV, including the ones that cause cervical cancer. So by getting vaccinated against those strains, it can protect from ongoing exposure to those high-risk HPV subtypes that can lead to really quite devastating oropharyngeal cancers. In my gay MSM patients, anal cancers and penile cancers are almost always driven by HPV as well, so it protects them against that. So this is kind of to get on my pulpit and say, if you've not been vaccinated against HPV and you have ongoing risk, of course genital warts would be unfortunate and but of a nuisance, but those cancers, the anal cancers, the penile cancer, and the head and neck cancers are particularly dangerous and devastating, and it's a longevity channel, so that really interfere with longevity. So that's basically what I want to discuss today. I think that sexually transmitted infections, they're out there. I see them every day in my clinical practice as a dermatologist, and we have really fantastic tools, whether it's vaccination, whether it's PrEP and PEP, and then regular testing is critically important, in regular communication with one's partners. But with optimization of sexual function that we discussed in a previous discussion, we'll discuss later, you can be confident that you are reducing that risk of having these potentially best annoying and at worst devastating sexually transmitted like HIV and or human papillomavirus related cancers. If you like this content, please subscribe, comment, sign up for alerts for the channel. It's really helpful, and we'll have a lot of additional content about longevity, sexual health in the coming days. Thanks a lot.